also increased exponentially in the last a decade or two. They are usually believed to be because of a disbalance which exists in the body of certain individuals, wherein the Th2 type of cytokine profile has a heavier weight. It predominates over Th1 type of cytokine profile. And because of the cytokines that are recognized as type 2, they have a different style of fighting, wherein eosinophilic inflammation becomes the organ of offense. Allergic diseases here, their impact on lives of individual. There are about 15 to 20% children at any given point in time who are suffering from one allergic disease or the other. It has its ramifications which impress upon the school performance of the child. It jeopardizes the family participation. It incurs to them financial repercussions, and it's a constant source of worry and anxiety, may even lead to depression, and if of a very severe type, can even lead to suicidal ideations. Because of them, the sleep of the child or even the adult, if he is suffering from it, is disturbed, and therefore the ramifications of the consequences of allergy are into our day-to-day social, family, school, and work field lives. To understand allergy, we need to understand atopy. Atopy means that there are certain people who are genetically primed. That is to say, they have certain genes on their chromosome because of which they have a tendency to produce more of IgE type of antibodies instead of IgG or IgM types, which become proportionately less. And therefore, the type of cytokines and the inflammation that ultimately results, because inflammation is ultimately our body's defense mechanism. It's fury of the body against any invader or insulter. So this category of people do have strong family relations, which provides us the basis to discover them in the history. If you don't have any allergy, say the chances of you developing allergy in your lifetime are about 10 to 15% because of mutations. But if any one of your brother or sister is an allergic child, then the chances are doubled. From 15%, it becomes about 32%. And if any of your parent is suffering from some allergic disease, the chances of you becoming an allergic child becomes 3 times. If without any history of atopy, Because of mutation, chances were X, they become 3X. And the influence of mother is definitely more than that of father. Because this is not merely an expression of our genetics, this is also an expression of our epigenetic influences. That means that whatsoever our genetic makeup is. But while during our gestation period, we remain in the womb, the atmosphere to us is provided by the mother. And there are impacts then happen on our immunological system because of that maternal atmosphere in which we live for, say, 9 months' time. So, mother is more influential in this matter as compared to father. And if any one of the two do have atopy or allergy, then our chances of becoming an allergic patient become 3 times as compared to a person who does not have atopy or allergy. For father, the chances are about 40%, while for mother, they are about 50%. And if both the parents, father and mother both, are allergic, then chances of our becoming allergic mounts to about 4 times. And if both parents have had similar type of allergy, say both have asthma, or both have allergic dermatitis, or if both had allergic rhinitis, or both had allergic conjunctivitis, that means the allergy of the same type was present in both the parents, then the chances increase to 5 times. The incidence of allergy has also been discovered to be more in monozygotic twins instead of dizygotic twins. So it's an interplay of genetics and epigenetics that ultimately influences our cytokine profile, whether it would be Th2 type and to what extent, and what type of inflammation as a response mechanism we would develop on being coming in interaction with a peculiar type of environment to which we have disturbed relationship. As I said, therefore, allergic diseases are an interplay of immune response controller genes and the environment. You have the example that allergic rhinitis, which is also called hay fever, allergic dermatitis, and asthma, they share areas of commonness among them, because allergy do not certainly speak in singular language, it speaks in plural language. When it causes problem in the eye, it is allergic conjunctivitis. When it causes problem in the nose, it is allergic rhinitis. When it causes problem in the skin, it becomes allergic dermatitis. Other reflections in the skin are erythema multiforme, urticaria, angioedema. So, different type of allergies have something in common, and a person who is representing his allergy in one particular fashion at one given point of time may switch and change to a different style of its expression in different part of his lifespan. I may have allergic dermatitis in my infancy, but I may develop asthma when I become a child or an adolescent. In my adulthood, I may start expressing like allergic rhinitis, or any of the two, or any of the three, or any of the multiple may even coexist in the same person. So among different forms of allergy, allergic rhinitis is the largest chunk. The singular allergy among this spectrum of allergy, which has the maximum representation, is that of allergic rhinitis. It constitutes more than 50% of all allergies. There is a concept of what we call as allergic march. This is sequential development of allergic diseases with their manifestations during early childhood and then over period of time. How does things change? Because these are different type of allergy manifestations that can happen in the, if we see in the lifespan, this on this side of the graph, you see this is 0 year and this is 15 year. You see that as we move in our life, in our age, the food allergies were earliest to take a start and peak around 6 to 8, 10 months and remain so up to 1 year of age, and then they start declining and gradually come to their lower end. What does that mean? It means that food allergies are the heralders who would tell us for the first time that you may have an allergic problem, that you can have a Th2 type of cytokine profile. But this phenomena reaches its peak in the first year of life, and then you would find that to so many things to which you were allergic in that part of life gradually may decrease over a period of time, and you may outgrow food allergy by the time you grow. And therefore, the total number of population which was suffering from food allergy reaches its peak when the sufferers of it outgrow that age, it gradually comes down. Atopic dermatitis is next to reach its peak. And similarly, by 7-10 years, it gradually comes down. But presence of atopic dermatitis in early phase of life from 1 to 5-6 years, this is the peak time for atopic dermatitis. If it is present in a child, again, this would be an indicator, a pointer that what is the path on which this child is growing, and that he may develop asthma in days to come, which can later be accompanied by allergic rhinitis. So when you have food allergy in early life or atopic dermatitis in early life, every attempt must sincerely be done to see to it that allergy does not progress further to translate or switch into other forms of allergy, and we can certainly stop this development by certain corrections that can be brought at this point in time. In fact, if we believe that a family has both father and mother suffering from atopy, or one of the elder brothers is also suffering from atopy, we must take caution and all those methods with which allergy in the newborn could be prevented, and if not prevented, at least subdued, not allowed to grow faster. You see, 70% of the patient with severe atopic dermatitis develop asthma. The relationship is so much so that about 2/3 patients of severe atopic dermatitis would later on develop asthma. While if the atopic dermatitis was mild, then about 1/3 of the patients would develop it. While in normal population, tendency to grow into asthma is only 8%. That means more than the normal population, it is about 4 times. And this is about 9 times. So, more than the normal population, presence of atopic dermatitis would tell us that the likelihood of me developing into asthma has grown by 4-fold. And if I have had severe atopic dermatitis, then the risk has gone at least 9 times of me developing asthma in later life. So this can become a predictor of asthma. Now, coming on to the body or the corpus of the discussion that I am supposed to do with you, childhood allergic rhinitis and asthma link. Similarly, as I have told you with atopic dermatitis, there is a relationship of asthma with allergic rhinitis and allergic rhinitis with asthma. You see that an adult with a family history of asthma or rhinitis, I am talking about family history, has a risk of 3 to 4-fold of developing asthma. This I have already told you previously. And there is 2 to 6-fold risk of developing allergic rhinitis over an adult without a family history. So if there is no family history in the family, say there is a possibility of you developing allergic rhinitis or asthma X times. And if family history is also present, the risk of asthma would increase by 300 to 400%, and risk of developing allergic rhinitis will grow by 200 to 600% more. Similarly, this was about family history. Now, if you are a child and you have allergic rhinitis, childhood allergic rhinitis, this would increase chances of developing asthma to the tune of more than 7 folds in the pre-adolescence, more than 4 folds in the adolescence, and more than 3 folds in the middle age. So, if allergic rhinitis is present in your childhood, you are more than 7 times likely to develop asthma in pre-adolescence. But as you would move towards adolescence, some of it would go away. Some people, some children would outgrow this tendency, and this would remain only 4-fold. And by middle age, some more will outgrow this tendency, and only 3-fold would even then continue to remain asthmatics. So, presence of allergic rhinitis in childhood becomes a marker of the tendency of developing asthma in later life. If I need to explain to you about naso-bronchial allergy, we understand that they are not two different parts, although of course one is covered by ENT specialists, the nose part, while the chest part is being looked after by pulmonologists, but the division is very arbitrary. Nose is only a gateway of whatsoever enters and reaches our airways and then to the lung. So they are not separated internally. Although, of course, when the problem is in the nose, we call it allergic rhinitis. When the problem is in the bronchial tree, especially the smaller airways, we call it asthma. So on one end of it, it is called asthma, and on the initial end of it, this phenomena that is resulting because of inflammation is called allergic rhinitis. Now, all those who are suffering from allergic rhinitis may proceed and develop asthma over a period of time, while all those who suffer from asthma first may proceed and develop allergic rhinitis over a period of time. So it's a bi-directional movement that is possible. And in between, you would come across a population of children who would have both allergic rhinitis as well as asthma. These patient profiles, or what we call as phenotypes. Asthma is a phenotype, allergic rhinitis another phenotype, and a mixture of the two is a combination of the two phenotypes. These phenotypes are not stable phenotypes. Even in the lifetime, a patient may move from here to the other end and may stop manifesting asthma. And a person suffering from allergic rhinitis may also move towards asthma and stop manifesting allergic rhinitis, or may continue to manifest a intermediary position with a percentage of asthma and a percentage of allergic rhinitis throughout their lifetime. That is to say that the patient profile is dynamic in nature, and patient frequently shift between these categories. To dilate further, see, which is genetically derived, wherein somebody develops IgE antibodies, is common to both these phenotypes, be it asthma or be it allergic rhinitis. 75% of adults with asthma have allergic rhinitis. This is so very common that there are incidences of co-presence. 50% of the people with allergic rhinitis have asthma, while you treat rhinitis, it also improves symptom of asthma. So when you have one, the presence of other is seen this way or this way. And then treatment of allergic rhinitis does help in winning over the symptoms of asthma. Up to 84% of all asthmatic patients have allergic rhinitis. This is in totality. This was about adults. Herein, we are taking cognizance of both adults and children. So 84% of asthmatics have allergic rhinitis, especially during asthma flare-up. So when asthma flare-ups, you see that the cases of flare-up of allergic rhinitis is also becomes manifest. And therefore, you can find that both things are coming together in this person. Otherwise, one thing may remain hidden. Up to 60% of patients with asthma have sinusitis. And when I talk of persistent asthma, because the majority of asthma is intermittent asthma, about 40 to 60%. And rest is persistent asthma. When I come to persistent asthma, in children less than 18 years of age, you would find that allergic rhinitis and asthma were together in 99.6% cases. So in cases of persistent asthma, allergic rhinitis is invariably present. Therefore, what is said is that in every case of asthma, you must search for allergic rhinitis. And in every case of allergic rhinitis, you must put that person for spirometric analysis to detect whether or not there is presence of asthma also. 76% of asthmatic patients reported presence of rhinitis before onset of asthma. So rhinitis may happen earlier than the asthma also. You have seen in the allergic march that it was expressed to have peaked later than the asthma, but it can express earlier than that also. Now, the genetic background of those who suffer from asthma and allergic rhinitis is almost similar. And the environmental triggers that they share among themselves are also similar. This is also an emphasis of that there is something in common. Then we see on the basis of anatomy, we find that the inner lining of both are lined with pseudo-stratified ciliated columnar epithelium. So inner lining is also continuous and of the same type. And it contains mucus secreting goblet cells, which is again a common factor. Then not only structurally, even functionally they are together. There is a reflex called naso-bronchial reflux. That means when you irritate the nose, the bronchus also have the expressions of the irritation that is being done to the nose. So you are irritating nose, but expressions are coming not in the nose. Although of course they are coming in the nose, but in addition they are also coming in the bronchi. Then post-nasal drip. When you have allergic rhinitis, the secretions of the nose drip from the front nares, as well as when you lie down, they drip in your oropharynx from the posterior nares. And because of the irritation that they cause in the throat, there is post-nasal drip causing upper airway cough syndrome. And contraction and inflammation of the bronchial smooth muscles also do take place. When you have allergic rhinitis, naturally you have edema of the nasal mucosa. you have more of the mucus production in the nose, which blocks your nose. Your nose is congested. Therefore, it is difficult to breathe through the nose, or you are not able to breathe at all. What are the consequences of this block? As we understand, nose has a very important function of filtering microbes, filtering the suspended particulate matter, and nose adds temperature to the cold air that we inhale. It also adds moisture to the air that we inhale and condition it in a way so that it becomes less harmful and more convenient for the lower airways. But when nose becomes closed, block, during allergic rhinitis, people have a tendency for mouth breathing. There is one more thing. With allergic rhinitis, you have recurrent infections happening because the cilia beat slowly, and therefore they are not able to clean the microbes properly. It also invites viral infections very frequently. As a consequence of that, the lymphoid tissue present in the nasopharynx and in the Waldear's ring, it increases in size. So you would also find that those who suffer from allergic rhinitis also do have adenoids, which are swollen, which further adds to the block in the nasal passage, being present in the nasopharynx. The consequence again the same, that you breathe through mouth. When you breathe through mouth, the filtration stops. The cold air enters as cold air in the lower airway. The addition of moisture does not take place to it. So, as in this cold season, the outside air becomes dry and cold. So this dry and cold air, when goes inside our lower airway, it irritates and cracks the mucosa of the lower airway. From those cracks, from those injuries in the epithelium, allergens also find an access to the immunological system of our body. As a consequence, eosinophilic inflammation, which is tendency of such people, does happen in the lower airway also. So presence of allergic rhinitis leading to adenoids do increase the chances of somebody developing asthma. That is how they are together, and that is how they usually coexist. I have already said that the triggers which flare up or which precipitate rhinitis and which precipitate asthma are almost the same. There are pollens which represent the outdoor instigator. Then there are chemical fumes. Chemicals are there inside the house, chemicals are there outside the house. The diesel exhaust particle, the nitrous oxide, the sulfur oxide, the ozone, they are poisonous gases, a chemical anarchy in the outside atmosphere. But that is not the end of the world. It even happens inside the house, four walls of the house. We bring heat to hit the mosquito, but we do not know that the heat also hits us. So the chemical fumes, the tobacco smoke, environmental tobacco smoke for children, and direct smoke for those who actually smoke. So there are plural factors, but these factors are common to either of them. Then there is an immune pathological association. I have already said that if you irritate nose, you find that there are also manifestations of bronchial constriction happening in the bronchial tree. Similarly, the reverse is also true. It have been tested during the experimental conditions that if you irritate the lower airway directly, then you find that there is greater amount of eosinophils and there is mast cell degranulation also in the nasal mucosa. So on irritating nose, you have bronchial consequences. On bronchial irritation, you have nasal consequences. The circuit is both ways. They are linked together. They are married together. If you treat rhinitis, naturally, the rhinitis would be addressed. But this also helps controlling asthma expression. The symptoms of asthma decrease while you treat allergic rhinitis. The exercise-induced asthma decreases. There is decrease in the bronchial hyperreactivity. There is decrease in exhaled nitrous oxide, which is a marker of bronchial eosinophilic inflammation. There is decrease in H2O2, which shows that the free oxygen radicals have now come down. Then there is decrease in acute asthma exacerbations. And there are lesser chances to the tune of 61% of hospitalization because of asthma. And how do you achieve that? You achieve that by treating only rhinitis. So treating rhinitis is an essential address to which we must post our therapy while we target for management of asthma also. Now you see, whenever these two organs are triggered for inflammation or for flare-up, the two respond in complementary fashion, but in the same direction. This is that we are challenging these mucosas of the nose and of the bronchus by histamine or by methacholine, and then we will see the response. We see that when we challenge, this is severity of symptom. The severity of the symptom increases. Then after some time, say after 2 hours, it goes down. And then eosinophils and other basophils, mast cells, they are recruited from the circulation, from the systemic circulation. And the same response happens again in a more severe way and for prolonged length of time. So there is a dual inflammatory response, the initial response and the secondary response. In the first phase, you see that there is bronchial constriction, bronchoconstriction, which gradually gets relieved. But then with secondary response, the bronchial constriction and the bronchial edema and the nasal mucosal edema goes down. And this decrease is much lower as compared to the first decrease. This was the first decrease. This is the later decrease. Therefore, with initially, if your child starts recovering in 2-3 hours, that does not mean a secondary phenomena is not there for you to be tackled. We need to handle the secondary phenomena also. There is a concept of what we call as minimum persistent inflammation. Now let us understand what is this minimum persistent inflammation. All those who are genetically primed and are living in an atmosphere which is hostile to them, the interaction of this environment with their genetic profile is not in concordance, but there is a lot of discordance, because of which there is eosinophilic inflammation in their vital organs, say nose and bronchial tree. Whatsoever you do, this inflammation or this fire that is burning in these areas cannot be totally extinguished. It can be reduced to a minimum level, but you cannot take away totally. This minimum fire or inflammation, the word inflammation contains flame in itself. It's a chemical fire. So this minimum inflammation which goes on in the respiratory tree ultimately leads to permanent damage happening to that organ, which is what we call as airway remodulation. But if his fire is kept low, then the damage would also be less. If it burns fast, the amount of damage that it would create would be far, far, far more than otherwise. Therefore, there is every effort which is made to keep this fire burn as less as possible. This minimum persistent inflammation also happens in nose in a similar fashion. And because of it, you have inferior turbinate hypertrophy. Although, of course, because there are no smooth muscles in the nose, the remodulation is less. But nonetheless, it do happen. So, there is a protocol that we need to keep this inflammation less. And for that, anti-inflammatory medication need to be continued for longer length of time and not stop, because we know that when the clinical features are no more there, a subclinical inflammation is still damaging our nasal mucosa, nasal lining, and the bronchial structures. Number two, if this fire is present and is not kept low, then this reduces the threshold of flare-ups because of its priming effect. It is like adding fuel to the fire. A fire is already there, and if you add a trigger factor to stimulate or to insult your airways or nasal mucosa, it again flares up fast. So this also provides a priming effect. Therefore, to keep these recurrent inflammations becoming flared up time and again, we need to address to this minimum persistent inflammation and keep it as low as possible. For management of allergic symptoms, let us see what tools we have in our armory. The first tool is antihistaminic, and we will also see that these are the features of allergic rhinitis: sneezing, which is paroxysmal; rhinorrhea, that means running nose; congestion, that means blocked nose; nasal itch, that means nasal pruritus; and eye symptoms, because you have a common association in about 40% cases of allergic rhinitis. You also have allergic conjunctivitis. And these are various agents that can be used to tackle these problems. Antihistaminics handle sneeze, itch, and eye symptoms. The decongestants handle only congestion. The ipratropium handles only rhinorrhea. Ipratropium is an anticholinergic. Mucolytics have no role in it because they do not handle any of these. Leukotriene receptor antagonists handle most of them, but not itch. But one that addresses to each one of them and more effectively than anyone else is nasal steroid, the topical application of steroid in the nose. It addresses to sneeze, it addresses to rhinorrhea, it addresses to congestion, it addresses to itch, and it addresses to eye symptoms. So in all faculties, we find that nasal steroids are the best to be used as one that keeps the anti-inflammatory effect for the nose, and the same holds good for bronchial airways also. When you control nasal inflammation, as I said, the bronchial asthma symptoms are also controlled to the tune of our significant degree. And this maximizes the outcome of asthma therapy. There is a rationale of anti-inflammatory treatment of allergic rhinosinusitis with intranasal steroids and with non-sedating histamine H1 blockers. Because steroid take, say, 10-15 days time to take over their effect. So always in the initial phase, intranasal steroids and H1 blocker antihistaminics are taken together, say after 7 to 15 days, 1 to 2 weeks, antihistaminics are taken away, and by then the intranasal topical steroid is sufficient enough to take the total charge of the nasal symptoms. It inhibits local inflammation, it relieves obstruction of the osteomeatal apparatus, it restores the mucociliary function, stimulates host defense and the repair mechanisms, and it promotes bacterial clearance, which I said initially that they become more in allergic rhinitis, particularly viral infection, because cilia beat slowly because of tenacious mucus and because of the ciliotoxic effect of pollutants and irritants. I would like to conclude my talk by giving certain carry-home messages, which are that allergic rhinitis is frequently misdiagnosed. We must learn to diagnose it properly. If somebody has itch in the nose, time and again, he is doing like this. Whenever you find he is off mind and he is doing like this. If he has paroxysmal sneezing, which has a geographical or a smell relation, if he either has running nose or blocked nose, and if there is a background of atopy in the family or to himself, say he was a patient of atopic dermatitis to begin with, or he have had food allergy initially when he was young. This is personal history of atopy. And if either elder brother or sister or mother or father or both or several of them suffer from similar problems, then this puts thing in the correct perspective that what we are handling is allergic rhinitis and not a rhinitis because of regions other than this. Other regions can be vasomotor rhinitis, non-allergic rhinitis, gestational rhinitis, viral, part of viral URTI, etc., etc. And allergic problem would be a recurrent problem. It may also be a seasonal problem. If you have a disturbed relation with some pollen grain which happens in that season, well, you would have manifestations in that particular season. There is a strong evidence to support a bidirectional naso-bronchial connection. Then clinical picture switch depending on target of inflammation, whether it is nose, sinus or lower airways. Even they may collectively remain present in the same person. Also, they are connected together as a part of larger systemic inflammatory syndrome. As I said, there is an initial response and there is a secondary response. The initial response soldiers are local soldiers, local chemicals. But soldiers for secondary response, which is much augmented and larger, are recruited from the bone marrow, from the system. And therefore, there is a system connection to it also. Because all this is caused by inflammation, therefore, inflammation is therefore the rational therapeutic target. And steroids are most effective broad spectrum anti-inflammatory for target delivery and systemic use. If you treat these needs now, maybe that you would be able to find your success in preventing wheeze tomorrow. Thank you very much. Now, I wait for questions if there are any to be asked to me so that I can answer them.
Thank you, sir, for the wonderful session. And before you would complete your session, we have number of questions which have come up queries. So I'll take queries one by one, and you can answer to the delicate or concerned person and to others. So the first query which we have got is from Dr. Manjusha, who is from Bangalore. She says that in terms of management of atopic march, it started with management of a dermatitis. So what should be the treatment in order to avoid the further complications?
Okay. For management of dermatitis, you have the specialized protocol that would need address. But her issue is to safeguard and prevent further march to progress ahead. In that situation, I would suggest to go for a skin prick test or an identification of specific IgEs in the blood to detect as to what are those allergens to which this particular person about whom we are talking is allergic. And the first thing is those triggers need to be avoided. This is what is called trigger avoidance. Number two, that there are things that need to be added to his diet, and there are things to be avoided. If she might have heard of the lecture of Dr. H. Parmesh during Allergy Con, there was a detailed lecture about how to arrest the progression of the allergic march. She is from Bangalore, and Dr. H. Parmesh, who have also been my teacher and my initiator on the path of allergy, is from Bangalore. He was the founder, director of the Lakeside Hospital in the Ulsur Lake area. I think that lecture was an eye-opener for anybody that how can these things be prevented. I would suggest her to talk to Dr. H. Parmesh, because this would be a very lengthy discussion. And vitamin D is important. We should see to it that we don't suffer from deficiency of vitamin D. We should not expose ourselves to pollutants. Then we must use more of fish, more of DHA. They are the substances which we must take fresh fruits and fresh vegetables to increase antioxidant concentration in our diet. Greater the antioxidants, better would that be. Continued breastfeeding for 6 months and not less, and no introduction of outside food by then. Delayed introduction of wheat by 9 months of age. Delayed introduction of anything coming from animal origin after 1 year of age. There are certain ways in which these things can be prevented. Next question, please.
Thank you, sir. So there is one query from Dr. Alok, is from Lucknow. He says, can we recommend nasal irrigation with the saline water in treatment of the severe allergic rhinitis? And for how long we can give in a child?
Only yesterday, I have had my talk on Zoom on nasal saline irrigation, which was as long as this lecture that I have taken today. Nasal saline irrigation is very, very helpful. It is culturally acceptable, and now patient friendly solutions has also come in market. This was used as neti in the yogic practices. It removes the cellular debris, the pollens, these dust particles trapped by nasal mucus. Nasal mucus, if it is more thick and sticky, it also takes away the chemicals of inflammation. And if given before intranasal steroids in the nose, it increases efficiency of intranasal steroid medication by 47%. And how does that is done? That is done because now the medicine directly goes to the mucosa. Otherwise, there were large number of things in the nose which were serving as a barrier, not allowing the medication to reach the nose. So I am a strong advocate. If you have nasal problem, keep your nose clean, make it a regular habit. If you are a patient of allergic rhinitis, or there are several other uses of nasal saline irrigation, of which I strongly recommend it to be given to patients of nasal allergy. Next question, please.
Thank you, sir. So we have one more query from Dr. Vijaya, who is from Hyderabad. She asked that in management of asthma and ARG overlap, as you mentioned, to do a skin prick test.
Yes.
So, which skin prick do you prefer? Because India being a various seasonal country, so there are lots of allergen. So, should we go for a regional specific, or should we categorize into a broader testing of the allergens?
Look, my pattern is that first you must take a very detailed history and examination of the patient and a survey of his dwelling and environment to find out as to what can be possible instigators in this particular case. I secondly go for detection of specific IgE in that child. By use of these two things, by clinical assessment and by the knowledge that I gain from a specific IgE's presence, I can definitely shortlist the number of allergens for which I need to do this skin prick test. Because several allergens are also cross-reactive. I must have the understanding of these cross-reacting antigens also. The skin prick test is an assessment, a stage ahead of detecting specific IgE. Specific IgE means specific IgE to some allergen has developed. The skin prick test positivity means that specific IgE has also attached now to basophils and mast cell and is ready to degranulate if you challenge. Because all sensitization does not ultimately lead to development of an allergic disease. But if you want to protect these things from not growing, you will have to address each one of them and not let them have the chance of this growth. I refer to a senior allergist from Vellore who is now settled in America, Dr. Vedantan, who said that if you detect specific IgE, that is the right time that you must see to it that even the second stage to those things against which specific IgE has developed not to take place if you want further progression to be arrested. There are such researches wherein total IgE have been assessed in the newborn children in their early lives, say within 1 month, neonatal period 28 days. And if total IgE of a newborn in first 28 days is higher than the expected value, and if he is positive in the asthma predictive index, or there is a strong family history of allergy, the maneuvering of this child not to develop allergic march must start from there and without delay, because it is ultimately an expression of the epigenetic period which starts from the womb and continues only for initial days of life. Once it is settled in, you can only retard its progression, not stop it completely. So, initial 2-3 months of life of a child are very, very important from the point of view of prevention of development and progression of allergic march, when the influences of epigenetic period are already in process and have not completely end. In next 2-3 months, they become fixed and rigid, and that becomes gradually more difficult to alter the course of allergic march. Next question.
Thank you, sir. So there is one query from Dr. Mukesh, who is from Mumbai. He asks us that what do you feel, sir, Dr. Raj, in usage of the omalizumab in management of the allergic rhinitis?
Omalizumab is a good medicine. It is the medicine of future in IgE directed allergies. But the cost is prohibitive. And then you need to identify the peculiar specific phenotype to which it would be beneficial. It cannot be given to all and sundry suffering from allergy. This is an anti-IgE antibody, but the cost of treatment, as I said, may be peanuts for Western population in economically deprived, and the availability is second problem besides our economic constraints. Since this is present in India for last about 8-10 years, but its presence is very meager beyond big metropolitan cities of India. And there too, when it was asked to senior pulmonologists of big corporate hospitals, they said, yes, I have used in 6-7 patients, I have used in 3 patients. So, despite its presence, this was not used as much as it should have been. Cost is a constraint. Initially, Cipla brought a cost-effective brand of it, but later on, because there was no uptake from market, it has to stop selling that brand. So this is good to talk theory, but when we are faced with the real life challenges, probably good things don't find a foothold to grow as much as they must. Next question, please.
There is one query from Dr. Bishwas, who is from Patna. He says that in patient who comes with most of the patients nowadays are with allergy and asthma overlap. So should we first treat allergy or asthma, or should we treat both at the same time?
Allergy and asthma overlap is nothing. I am not aware of this condition. Asthma is allergic. I think he is talking about asthma COPD overlap, because there is no term even in GINA about allergy and asthma overlap. Allergy, asthma by and large in children is allergic in nature. I am wearing this shirt. I have a vest inside. I have a pant down and I have a handkerchief in my pocket. Although name of all these things are different, but all of them are made from cotton, from cloth. So allergy is the cloth with which they are the allergy is the alphabet with which the disease has different syntax. The same allergy in eye becomes allergic conjunctivitis, in nose it becomes allergic rhinitis, in skin it becomes allergic dermatitis, in bronchial tree it becomes asthma. So there is nothing like overlap in them. One is the effect, other is the cause. The cause of asthma in most children, although of course there are some non-atopic asthma children also, but in pediatric population it is minuscule. Majority of the children that we see suffering from asthma, the cause is allergy. Next question, please.
So again, we have a query on a skin prick test. So the doctor wants to know, again, the doctor is from Hyderabad. The
Yes.
again, he asks a question. Doctor, again, in a skin prick test, should I test for specific, for how many allergens? Should I go for 24 set kit, or should I go for a 48 test kit?
I think if somebody is suffering from allergy of multiple things, it is very difficult to treat him by allergen immunotherapy. I said there is Dr. Arif Ahmad in Hyderabad. He is a great friend of mine and a wonderful allergist there. He had been to our place and I have been to his place several times. Dr. Arif would be a good resource person for this gentleman doctor talking to me from Hyderabad. As I said, we must first try to shortlist them to as few as possible. And the history of the patient, his examination, then his specific IG profile, as I will get, would help me in identifying what allergens he is suffering from. Perennial problem. And on short listing, only then should we go for prick test and not for many, fewer the better. But then those fewer number must come out of the wisdom of clinical scrutiny, of the specific IgE profile study, and not randomly going for a specific skin prick test. Because I feel that's my issue. There are several allergists who advocate that specific IG is not required, even if done with immunocap. When skin prick test is the last word, why do you go for that? It can definitely be argued. But for children patient, I find it more convenient to see that profile also and only then decide for skin prick test, because what is the ultimate target? The ultimate target is identification of a trigger, and the trigger must be an allergen. And with that allergen, we are going to behave in two ways. Number one, by allergen avoidance, and number two, by allergen specific immunotherapy. That allergen specific immunotherapy can be sublingual, and I think that is the way for the future. But if somebody has allergy with several allergens, then probably this allergen specific immunotherapy is not going to be successful. If there are fewer allergens, then the success rate of allergen immunotherapy is much, much superior. And then this immunotherapy is no substitute for pharmacotherapy. Pharmacotherapy is the first line of our action. Immunotherapy is only a later addition. Next question.
So now the rest of the questions and you have answered the most because which you have elaborated more of skin prick test. The last of had a query on that, and I guess the others also need to say the same.
In the country, Dr. Arif Ahmed at Hyderabad, Dr. Nagaraju in Chennai, and Dr. Vedantan at Vellore. Besides a great pulmonologist and an allergist and an environmentalist, Dr. H. Parmesh in Bangalore. These are 4 people who have done maximum work throughout length and breadth of this country, and I stoop my head and fold my hands in the respect of these people who have given me something to which now I am able to talk to you.
Thank you, sir. So thank you. I would like to thank you from on behalf of Lupin for accepting the invite and being sharing your thoughts on asthma and allergy. Yes, today it's about both are the same side of a coin, and I'm sure all our delegates have got all your answered their queries, and most of them were very excited and continues talking about skin prick test. It was good. Most of doctors said it was good because they have more clarity on the atopic march and also on the usage of the skin prick test to them, and also the usage of the current inflammation which you have highlighted into MTP slides. Thank you, sir, for spending the your time in the evening and for addressing the audience. Thank you, sir, so much.